I'm Dr. Mike Christie. You'll see my other three partners here in a few minutes. I'm the only one with gray hair, so that makes me the oldest, and therefore I get the opportunity to kind of guide you through tonight. My designated job here at the beginning is to kind of introduce you to our practice. Because as you can see from the ad in the paper, one of our goals was to help you as potential patients kind of start making decisions about joint replacement, understanding it, figuring out how to pick a doctor, how to figure out how to pick a practice, and that's a very difficult thing without some knowledge. And so what we're going to do tonight is talk about joint replacement. And this is just a patient, a long leg view, so you're seeing both hips, knees, and ankles. And on your left is a patient before surgery. You can tell that the legs are bowed. Those white lines that you see projected are the weight lines. The way we're designed is our hip, knees, and ankle fall on a plumb line, and as you start to get arthritis on the inner side of your knee, you get bow-legged. And some of you may be that way. Some of you may be knock-kneed. That's arthritis on the other side of the knee. When we put a knee replacement in, and that's what you see on the picture on the right, is 2 knee replacements, and the goal, of course, is to restore alignment. So we want to straighten the legs for the same reason that when you put new tires on your car, you get the front end aligned, because we want the new tires to last a long time. So, as you can tell from the title of our practice, it's Southern Joint Replacement Institute, and the question is always, do you just do joint replacements? And the answer is pretty much yes. When we started this practice 10 years ago, I actually came to Nashville 25 years ago to Vandy as their joint replacement surgeon. We wanted to have a practice that was very specifically focused on patients and joint replacement, because we knew that if we did it well, we were going to have to do a lot of it, and we were going to have to work together to achieve the goals. So there are now 4 of us. We do primarily joint replacement. And does it make a difference? Yeah, the literature out there says, like you might expect, if you practice the piano every day, you're a better piano player. You may not be the best piano player, but you're better if you practice every day. We have done, in the 25 years that I've been doing this, our practice has done over 12,000 joint replacements. We did somewhere around 1,300 joint replacements last year. So we have a fair amount of experience. What else do we do? We try to manage the arthritis before it's surgical. So we want to do the things we can to keep patients going for a long time before their symptoms become severe enough that surgery is required. Sometimes that is lesser surgeries, like arthroscopy. Sometimes we have to manage joint replacements that have failed. That's what is called revision joint replacement. So if you have a painful or a loose or worn out hip or knee replacement, we take care of a lot of those. And then we take care of fractures primarily associated with joint replacement. So if you had a fracture around your hip prosthesis or around your knee prosthesis, or you had a hip fracture that required a hip replacement, those are the kind of things that we do. Our mission has always been to do that in a state-of-the-art fashion. We're going to talk a little bit about what that means here in a second. But integral to what we do is our emphasis on research and education. Research is what makes us better. Education is what communicates what we found out to others, patients, nurses, other surgeons, residents, and fellows. So we have to do all these things simultaneously to actually achieve our goal, which is to get you the best possible treatment. Research to us means that we look at what we've done. You can't tell how well you're doing unless you examine it. We then publish that information so that it helps not only the patients that we're taking care of, but our future patients. When we left Vanderbilt, one of our goals was to develop a comprehensive approach to total joint replacement. And I think those of you who visit other practices and then come visit us, I think you'll find a difference almost immediately when you get there. A new patient visit often includes x-rays that you may have not had before. Yeah, they're x-rays of your knees, but they're going to be more comprehensive x-rays than I think you've probably had before. We're going to talk to you about what the x-rays show. So you're going to see your x-rays. It is easy to see arthritis, it is easy to understand it, and it is easy to demonstrate it on an x-ray. And so we believe, since it's relatively straightforward to see, that you ought to have a chance to look at it and examine it and understand it. Once we get to the point where you need to have surgery, then you have to do some other things. We have a preoperative evaluation, and during that, you will not only get your normal EKG and lab work, but you'll see a hospitalist. A hospitalist is an internist that sees patients only in the hospital. And all of our patients are followed while they're in the hospital by a hospitalist. Our belief in having them seen before they get to the hospital is that we can manage the medical problems before you get there. If you're going to have a hip or a knee replacement, what we want is that you have the best possible chance of getting through that surgery well, intact, and without complication. And because we have the opportunity to plan this surgery, we do that in advance. And that may mean seeing your cardiologist. It certainly means seeing your dentist if you haven't seen them in 6 months. But our objectives are to do all the things we can do to make sure that your surgery goes well. In surgery, we have our own 4 operating rooms with the same staff every day. That makes our work lives great, and it makes things easier and better for our patients. The other important thing, I think, with surgery is the fact that anesthesia here is excellent, and we work very closely with anesthesia because we know that for you to be able to do your physical therapy well after surgery, you have to be comfortable. And pain management is critical to you being able to do your physical therapy. Your job after you have an operation is to get well. And the focus then is all about you getting movement in your knee, strengthen your muscles, and returning to a normal day-to-day life. So rehabilitation becomes a critical element. We discuss it a lot beforehand. You start exercises before surgery, and then those exercises continue afterwards. You'll be seen by our therapist. We have therapists in the office, of course, but we also review, even if you've done your therapy somewhere else, we review you at 6 months and a year and then yearly to make sure your muscles are staying strong and you're doing the appropriate exercises. Long-term follow-up, as you may know, with total hip and total knee replacement is critical because 10, 15 years, 20 years out, these things do wear. And they don't hurt when they're wearing out. The way they work is they have no feeling. So when one is wearing, it doesn't cause any pain until it's very late in the process. And if we follow you, then we can pick up those problems early rather than when there's a catastrophe awaiting us. Part of that comprehensive care requires integration. And so what you'll find with this practice is that we work closely with anesthesia and the hospitalists. We work closely with our PAs and nurse practitioners. They have a very good idea of what to expect and what you're going to be facing. The people who schedule our surgery know your needs and what needs to be done to get you safely through and scheduled. The unit upstairs in the hospital where you recover after surgery is managed at our direction. In other words, the program there is a total joint program that we've put together over the last couple of years. You'll see a case manager when you're there. A case manager is simply a person that's going to help you make sure that your appointments after surgery your physical therapy, and rehab is all organized so that you have no problems once you leave the hospital. When we talk about state-of-the-art care, what we mean is embracing meaningful advancements. And when you suffer arthritis and pain when you walk, you're constantly bombarded on television by ads and articles and newspaper clippings about the newest, greatest, whatever. To us, state-of-the-art means something that's going to make surgery safer, it's going to make it more predictable, it's going to make your recovery easier. Not all the changes you read about are advancements, and part of what we see as our job in this practice is helping you understand why some things are not better. For instance, this new article on minimally invasive knee surgery showing that minimally invasive knee surgery has a higher complication rate. Not surprising. If you can't see what you're doing, you're not going to do it as well. One of the things that I've enjoyed over the last 20 years are these little metal discs that go into knees. At least once a week I have a patient come in and say to me, can't you just put a little metal piece in between the bones so it doesn't hurt anymore? And it's a great idea, it's not a new idea. When I did my fellowship training back in the 80s, we were taking out that prosthesis called a McKeever. So it's just a little metal disc with a fin on it. And then I got into practice for a while, and in the 2000s we had the Rapicci knee, which is this unispacer. Another discovery, which was simply an old idea, retried. And then the newest version is out now, which is now a custom-made metal disc that goes in between the bones and the knee. The reasons there are 3 different versions is that none of them work. And as you might expect, bone rubbing on metal feels a lot like bone rubbing on bone. And so we don't use those kind of procedures. Research and education, as I've said, are very important to us. We have a fellowship, which is a surgeon who has finished his residency training, who spends an extra year with us learning how to do joint replacement. We've talked a bit about lifelong care and how important that is. That's not only important for you as a patient to make sure that your joint replacement is not wearing out and not failing, but it lets us know how what we have done has turned out. So if we know how knee prosthesis A looks at 15 and 20 years, then that helps us make recommendations to future patients. So not only do you help yourself, you help all those patients who come behind you. All of us now are involved in design of implants. We work with University of Tennessee, and Dr. DeBoer is working with Wright Medical, again, looking at the basic science of joint replacement, understanding anatomy, understanding the biomechanics, so that we can actually improve the devices that we use for patients and improve the procedures that we recommend to you. I want to finish my long-winded introduction here by just introducing my partners to you. Dave DeBoer did his medical degree and his master's in engineering at Vanderbilt, followed by his residency and fellowship there. He's now an assistant clinical professor, and David was my partner at Vanderbilt when we left 10 years ago. Craig Morrison is the next in line. Both Craig and David were residents with me when I was at Vanderbilt. I hand-selected these surgeons. They are great doctors, and importantly, they have great hands. So for a surgeon, not only do you have to be able to talk to patients, you have to be able to operate. And I can tell you that my 3 partners can operate. Craig went on and did his total joint fellowship at New England Baptist in Boston. And then most recently this year, we hired Jeff Hodrick. Jeff did his training at Duke and Penn State, did his residency at Duke, and then his fellowship with Aaron Hoffman, his fellowship in joint replacement with Aaron Hoffman. out in Utah. And Jeff fits the mold of my other two partners exactly. We are very, very happy to have him, and he can operate. So thank you. We are going to continue on with a couple other talks. Dave is going to tell you a little bit about arthritis.